Welcome to our interstitial lung disease review for Step 2. In this video, we will master the classification of ILD, how to recognize the classic clinical presentation, the diagnostic workup using pulmonary function tests and high-resolution CT, the major pneumoconioses, and treatment principles. Let's get started. Interstitial lung disease is a diverse group of disorders characterized by inflammation and progressive fibrosis of the lung interstitium. The end result is restrictive lung disease with stiff, scarred lungs that cannot expand normally. The major categories you need to know are idiopathic interstitial pneumonias, with idiopathic pulmonary fibrosis being the most common. Exposure-related disease, including the pneumoconioses and hypersensitivity pneumonitis. Drug-induced disease from agents like bleomycin, methotrexate, amiodarone, and nitrofurantoin. Connective tissue disease-associated ILD, seen with scleroderma, rheumatoid arthritis, and polymyositis, and granulomatous diseases like sarcoidosis and vasculitis. Drug-induced ILD is a high-yield topic. 3 chemotherapy agents to remember. Bleomycin, which causes dose-dependent pulmonary fibrosis and shows up classically in a Hodgkin lymphoma patient on the ABVD regimen. Busulfan, used in leukemia, and methotrexate, which is reversible if caught early. Among non-chemo drugs, amiodarone causes pulmonary toxicity that can develop over weeks to years. Nitrofurantoin causes ILD with chronic use for urinary tract infection prophylaxis. Radiation pneumonitis follows chest radiation. Step 2 Pearl. Always take a thorough medication and occupational exposure history when evaluating new ILD. The bleomycin lung in a young lymphoma patient is the classic test vignette. Idiopathic pulmonary fibrosis, or IPF, is the most common type of ILD and the prototype to know. It causes irreversible progressive fibrosis. Demographics: men aged 50 to 70, often with a smoking history. The defining histologic pattern is called usual interstitial pneumonia, or UIP. The course is relentless, with progressive dyspnea over months to years, and most patients die within 3 to 5 years of diagnosis. Genetic risk factors include telomere shortening and variants in the MUC5B gene. Step 2 Pearl. IPF is a diagnosis of exclusion. You must rule out connective tissue disease, drug toxicity, and pneumoconiosis before calling it idiopathic. Clinically, ILD presents with 2 hallmark symptoms: progressive exertional dyspnea that eventually progresses to dyspnea at rest, and a persistent nonproductive cough. Patients often have fatigue and may demonstrate rapid shallow breathing as compensation. On physical exam, the classic finding is bibasilar inspiratory crackles, often described as Velcro-like rolls because they sound like pulling apart strips of Velcro. In advanced disease, you see digital clubbing, cyanosis, and sometimes a loud inspiratory wheeze. Step 2 Pearl. The classic vignette is an older man with Velcro-like crackles, digital clubbing, and progressive dyspnea. That triad is IPF until proven otherwise. Pulmonary function tests show a restrictive pattern. The key concept: all lung volumes are reduced, but the ratios are preserved. Specifically, total lung capacity is decreased. Vital capacity and forced vital capacity are decreased. FEV1 may be normal or decreased. The FEV1 to FVC ratio is normal or even increased, typically above 0.7. The most sensitive parameter is the diffusing capacity for carbon monoxide, or DLCO, which drops early in ILD, sometimes before any symptoms or imaging changes. Step 2 Pearl. Restrictive disease preserves the ratio. Obstructive diseases like COPD and asthma drop the FEV1 to FVC ratio below 0.7. DLCO is the most sensitive marker of ILD. High-resolution CT, or HRCT, is the imaging gold standard for ILD. The classic usual interstitial pneumonia pattern is diagnostic of IPF and can avoid the need for biopsy. The classic UIP findings to memorize are honeycombing, which appears as clusters of subpleural cystic air spaces. This is the hallmark feature. Traction bronchiectasis, where fibrosis pulls airways open into irregular dilations. Reticular opacities with thickening of the interlobular septa, and a subpleural and basilar predominance. meaning the changes start at the lung bases just under the pleura. Ground glass opacities are minimal in IPF. Step 2 Pearl. Honeycombing at the lung bases means IPF until proven otherwise. Upper lobe fibrosis points instead to sarcoidosis or silicosis. Always screen for connective tissue disease in any newly diagnosed ILD, because rheumatic disease can present with ILD before the joint or skin findings appear. Routine labs include ANA, rheumatoid factor, and anti-CCP, anti-Jo1 antibodies, creatine kinase, and aldolase for myositis, and inflammatory markers like ESR and CRP. Classic associations to know. Scleroderma is linked to anti-SCL70, rheumatoid arthritis with anti-CCP, polymyositis, and antisynthetase syndrome with anti-Jo1. Lupus and Sjogren's syndrome also cause ILD. Step 2 Pearl. ILD can precede the autoimmune diagnosis. Antisynthetase syndrome presents with ILD plus inflammatory arthritis, mechanics hands, Raynaud phenomenon, and anti-Jo1 antibodies. Two pneumoconioses dominate step 2 questions. Asbestosis, seen in shipyard workers, plumbers, demolition workers, and insulation installers. Symptoms develop 20 to 30 years after exposure. Chest X-ray shows lower lobe fibrosis and calcified pleural plaques. Histology reveals ferruginous bodies. Importantly, asbestos increases the risk of bronchogenic carcinoma more than mesothelioma, though both occur. Silicosis, seen in miners, sandblasters, pottery, and glass workers. Chest X-ray shows upper lobe nodules with eggshell calcifications of alar lymph nodes. Major complications include increased risk of tuberculosis, progressive massive fibrosis, and cor pulmonale. Step 2 Pearl. Asbestos affects the lower lobes and silica affects the upper lobes. All silicosis patients need annual PPD screening for tuberculosis. 4 more occupational exposures to know. Berylliosis, seen in aerospace, ceramics, dental material, and electronics workers. It causes non-casseting granulomas that look identical to sarcoidosis on biopsy. It affects the upper lobes with hilar lymphadenopathy and is treated with chronic glucocorticoids. It also increases lung cancer risk. Coal workers' pneumoconiosis, from prolonged coal dust exposure, with upper lobe nodules. Coal workers with rheumatoid arthritis can develop Kaplan syndrome. It can progress to progressive massive fibrosis. Hypersensitivity pneumonitis. Classic examples are farmer's lung from moldy hay and pigeon breeder's lung from bird droppings. Pathophysiology involves type 3 and type 4 hypersensitivity. Treatment is removing the antigen and giving steroids. Byssinosis, seen in cotton textile workers, where symptoms classically worsen on Monday when workers return to work after the weekend off. Treatment of ILD has 3 components. First, supportive care applies to all forms of ILD. Smoking cessation, pulmonary rehabilitation, supplemental oxygen for hypoxemia, and vaccinations including influenza and pneumococcal. Second, for idiopathic pulmonary fibrosis specifically, antifibrotic agents slow disease progression. Pirfenidone inhibits TGF-beta-stimulated collagen synthesis. Nintedanib is a tyrosine kinase inhibitor targeting VEGF, PDGF, and fibroblast growth factor receptor. Both slow the decline in forced vital capacity. Third, for non-IPF ILD, treat the underlying cause and remove the exposure. Corticosteroids are useful for connective tissue disease-associated ILD and hypersensitivity pneumonitis. Step 2 Pearl. Lung transplant is the only curative option. Importantly, steroids do not help classic IPF, only acute exacerbations. Let's wrap up. Classification. IPF is the most common idiopathic ILD. Drug causes include bleomycin, methotrexate, amiodarone, and nitrofurantoin. Connective tissue causes include scleroderma, rheumatoid arthritis, and polymyositis. Clinical features: progressive exertional dyspnea, dry cough, Velcro-like bibasilar crackles, and digital clubbing in advanced disease. Diagnostics: pulmonary function tests show a restrictive pattern with reduced total lung capacity and forced vital capacity, with a preserved or elevated FEV1 to FVC ratio. DLCO is the most sensitive marker. HRCT shows honeycombing in traction bronchiectasis with subpleural and basilar predominance. Pneumoconiosis. Asbestos hits the lower lobes with pleural plaques and increases lung cancer risk. Silica hits the upper lobes with eggshell calcifications and increases tuberculosis risk. Beryllium causes sarcoid-like granulomas treated with steroids. Co-workers with rheumatoid arthritis get Kaplan syndrome. Treatment: smoking cessation and oxygen for everyone. For IPF, pirfenidone and nintedanib slow progression. Steroids help non-IPF ILD, but not classic IPF. Lung transplant is the only cure. Finally, the classic Step 2 traps. Velcro crackles plus clubbing equals IPF. Honeycombing at the lung bases equals UIP. Silicosis requires annual PPD screening. And steroids do not help classic IPF. Good luck on your exam.